Welcome to another lecture, guys. Advanced cardiac life support. Okay, so A, B, C, D of advanced cardiac life support. So systematic approach and management of cardiopulmonary emergencies, especially continuation of basic life support. Okay, so what we need to do in advanced cardiac life support? What are the A's, B's, C's, D's, and what are the common conditions that patient present with? What are the ECG findings in these common conditions? How you manage them? Everything we're going to talk about. Okay, so the A's: assess the patient, establish unresponsiveness, check the pulse or respirations, activate the emergency medical services, call for help. Defibrillator is very, very important. Get hold of automatic external defibrillator. Okay, now primary survey. Okay, so it's from the BLS protocols, basic life support, airway, breathing, circulation, defibrillation. Okay, so the D is defibrillation. Always assess and manage before moving to the next step. Okay, airway, what to do? Open the airway, head tilt, chin lift, jaw thrust. Okay, very, very important. Probably the two most common maneuvers, the two most important maneuvers, I should say, which will save lives. Okay, so do not forget head tilt, chin lift, jaw thrust. Okay, then you have breathing. Look, listen and feel. Give 2 rescue breaths. Watch for the chest rise and fall. Okay, after the airway, you're happy with the airway? Breathing. Okay, very, very important. C, as we know, is for circulation, so you check for pulse. Start CPR, 30 compressions, 2 respirations. Important, compressions are more important than respirations. Now, chest compressions alone are being suggested by the American Heart Association as a way to simplify CPR and improve bystander willingness to perform on an arrest patient. Chest compressions are more important than respirations. Defibrillation, know your defibrillation. Universal steps: power on, attach the pads, analyze the rhythm, and shock if it is necessary. Very, very important. Advanced cardiac life support, one thing you should know is defibrillation. Defibrillation. The most frequent rhythm in witness sudden cardiac arrest is ventricular fibrillation, or pulseless ventricular tachycardia, as we call it. Okay, why? Because it can rapidly deteriorate into ventricular fibrillation. Okay, the probability of successful defibrillation decreases over time, and if you don't treat it on time, if you do not intervene, if you don't have any idea about defibrillation, it can go into asystole. The patient can die. Okay, so defibrillation. Now, as I said, early defibrillation is increased survival. As you delay the defibrillation, the survival decreases. To put into perspective, the chances of success reduce to 7 to 10% each minute of delay with defibrillation. So that is very, very important to know. Remember by heart, early defibrillation, increased survival. ACLS, advanced cardiac life support. That's what we are talking today. Stay with me till the end. Okay, outcomes of rapid defibrillation by security officers in casinos were studied in one of the journals. Used about 105 patients with ventricular fibrillation. 53% survived to discharge, and obviously they were back to casino. Previously, there were less than 5% survival. Okay, another study, public access defibrillation survival after out-of-hospital cardiac care. Community-based trial, 30 in artificial group versus 15 in CPR. Average age 69.8. Cost about 9.85 million for the study. Okay. Now, after you've done all that, you've got to come back to a secondary survey. Again, airway, breathing, circulation, differential diagnosis. Assess and manage at each step before moving on. Airway, we now maintain the patency. Okay, head tilt, chin left. We've already know that's very important. Jaw thrust. Then, if you need, you may require an oral or a nasopharyngeal airway. Advanced management, if you are not able to maintain the airway, you might need an ETT tube. endotracheal tube, combi tube, or laryngeal mask airway. Okay, so airway, breathing, access adequacy of oxygen and ventilation, give oxygen, confirm that you've placed the airway properly and secure your endotracheal tube. Okay, next come to circulation, assess the rhythm, IV access, medication, fluid resuscitation is what's basically covered in circulation. So airway breathing circulation, differential diagnosis, look for and treat any reversible causes of arrest. Okay, all right, let's have a look at basic rhythm analysis. Okay, so this is basically an ECG analysis in advanced cardiac life support. Now why ECG? Because ECG will probably give you the diagnosis, and the treatment would depend upon how the ECG looks like. So the basic analysis: rate, is it too fast or too slow? Rhythm, whether it's regular or irregular. Is it normal looking QRS? Is it wide or narrow? Are the P waves present? What is the relationship of the P waves to the QRS complex? Okay, so rhythm analysis, got a lethal versus non-lethal. Then you got to assess whether shockable versus non-shakeable. Then too fast or too slow in the rhythm, symptomatic or asymptomatic. Okay. So lethal rhythms, okay, which ones? They can be divided into shockable and non-shockable. Shockable is where you can use a defibrillator to treat the patients. Ventricular fibrillation, pulseless ventricular tachycardia. Non-shockable, asystole and pulseless electrical activity, which are lethal rhythms. Okay, shockable, non-shockable, where you can use the defibrillator, or where you cannot use the defibrillator. Now the simple ones or non-lethal ones is basically sinus tachycardia, supraventricular or ventricular tachycardias, or if the heart rate is slow, sinus bradycardias or heart blocks. Okay, so non-lethal can be basically tachys or bradys. What is a symptomatic dysrhythmia? Any abnormal rhythm that produces signs or symptoms of hypoperfusion. Any abnormal rhythm that produces signs or symptoms of hypoperfusion, decreased blood supply, chest pain, shortness of breath, decreased consciousness, syncope, hypotension, shock, pulmonary congestion. Okay, it's a symptomatic dysrhythmia. Now remember, treat the patient, not the monitor. If the patient is symptomatic, it's an unstable rhythm. Okay, now this is the most interesting part of the talk today. Gonna practice the rhythms, how the ECGs look like, and how you manage the patient based on the ECG findings, how you come to the diagnosis, what are the typical ECG findings of different cardiac conditions. Right, 63-year-old man witnessed collapse while mowing the lawn. What is the rhythm? What is the management? Think about it. What do you see? Now go through step-by-step analysis of rhythm, rate, rhythm, QRS, P waves, abnormal waves. Okay, so this is ventricular fibrillations. Waves are rapid and irregular, and as you can see, there are no P waves or basically QRS complexes. It's very, very easy to identify. Ventricular fibrillation. Do not forget. Okay, it's also called as pulseless ventricular tachycardia. Okay, so this is the algorithm for ventricular fibrillation. You can pause the video here, have a look. Okay, so ACLS algorithm is primary survey, then you shock 360 joules, secondary survey, vasopressor, then shock again 360 joules, and if still not improving, antiarrhythmics like amiodarone, lidocaine, or IV magnesium, shock again. Now remember, do not forget cardiopulmonary resuscitation between the shocks. Don't stop CPR for anything except to assess patient or shock. Resume the CPR immediately after the shock for 5 cycles without checking rhythm until after 5 cycles or 30 compressions and 2 breathing CPR. Okay, second one. 79-year-old man, non-STEMI previous history. What is the rhythm and what is the management? When you see this bullet kind of picture, there is only one diagnosis, ventricular tachycardia. Okay, So the bullets kind of things. Rapid and regular, no P waves, wide QRS complexes. Ventricular tachycardia. Do not forget ventricular tachycardia. It can be a monomorphic or polymorphic ventricular tachycardia. Now, assume any wide complex tachycardia is ventricular tachycardia until proven otherwise. Supraventricular tachycardia with aberrant conduction may also have wide QRS complexes. Attempt to establish the diagnosis. Ischemia and VT go together. Now, treatment if pulseless, follow the algorithm. If stable, antiarrhythmics, amiodarone, lidocaine, procainamide. If the patient has a pulse but is unstable or not responding to medications, shock the patient. Treatments, antiarrhythmics are also pro-arrhythmic. One antiarrhythmic may help, more than one may harm. Antiarrhythmics can impair an already impaired heart. Electrical cardioversion should be the second intervention of choice. Okay, so that's a treatment of ventricular tachycardia. All right, let's move on to the next one. 60-year-old diabetic with chest pain. What's the rhythm? What's the management? What's the diagnosis? I'll pause for a second here so you can have a good look at it. So this is a normal ECG. Regular rate and rhythm, normal P and QRS. So you have to evaluate other causes of chest pain. So respiratory, musculoskeletal, trauma. Okay, it's normal ECG. Okay. 40-year-old woman found down, pulseless and apneic. What's the rhythm? What's the management? Pulseless, found down, apneic. This is pulseless electrical activity. Any organized electrical activity in a patient without a detectable pulse is pulseless electrical activity. Non-perfusing, treat the patient, not the monitor, and find the cause. Okay. Secondary survey and ABCD and primary survey is what's required. Okay. Now, primary survey and secondary survey, then you search for and treat the cause, and if it's still not improving, you give 1 milligram epinephrine and repeat every 3 to 5 minutes. Still not improving, in atropine. Find and treating the cause is the most important, non-shockable rhythm. The most effective treatment is to find and fix the underlying problem. So what causes pulseless electrical activity? Number one cause is hypovolemia. In children, it's hypoxia and respiratory arrest. There are lots and lots of other causes, but you can remember them as H and T's. Okay, so I'm not gonna talk about them. You can just pause this video here and have a look what are the causes, and many more. Okay, so I'll just list them here, but I'm not going to talk about them, otherwise this will just be a boring video, which we don't want it to be. And stay till the end because there's more interesting stuff coming up. Okay, more interesting ECGs coming up. Do not go anywhere. Okay, so 19-year-old man with palpitations. What's the rhythm? What's the management? What's your diagnosis? So this is a supraventricular tachycardia. Why? It's rapid 150-250 beats per minute, but they're regular. P waves cannot be positively identified and QRS is narrow. Supraventricular tachycardia. Remember that, okay? Treatment is consider vagal maneuvers, carotid sinus massage, Valsalva, eyeball massage, eyes to the face, digital rectal exam, or adenosine 6 milligrams, 12 milligrams. Treatment of unstable is cardioversion. Remember, cardioversion is not defibrillation. You have to use the defibrillation in the sync mode. It prevents delivering energy in the wrong part of the cardiac cycle. Electrical cardioversion is somewhat controversial. It's 100 to 200 to 300 to 360 joules is how we go. Atrial flutter may convert with low energy, but for polymorphic ventricular tachycardia, start with 200. All right, the guys in the emergency physicians usually start to tend with 360 though. Okay. Now be prepared. Patient on monitor, IV and oxygen, suction, airway, all is ready. Pre-medicate, conscious sedation. Remember, shocks are painful. Okay. So things to remember for electrical cardioversion. Preparation is everything. Now tachycardia, evaluate the patient. Lots of options based upon the rhythm in stable patient, unstable patient, basically then the shock. Remember again, treat the patient, not the monitor. Okay, so examples of stable tachycardias, you can have narrow or wide complex. You can pause the video here and have a look at them. I'm not going to talk about each one of them. The stable tachycardias. Okay, next one. 56-year-old woman with shortness of breath and chest pain. What's the rhythm? What is the management? It's very simple. So the treatment based on the patient's clinical picture: unstable, immediate cardioversion; stable, control the rate; diltiazem, esmolol, digoxin, provide anticoagulation. Remember again, treat the patient, not the monitor. So this is the treatment for atrial fibrillation or flutter. All right. You enjoying this? I'm sure you are. 78-year-old man found down, pulseless, and apneic, unknown duration. So rhythm and the management. Well, you may laugh at it because there's hardly any rhythm, and I think this is probably anyone can guess that this is. Okay, so 68-year-old woman with hip hypertension presents with dizziness. You do an ECG, you take a history exam, you've done everything. Now you do an ECG. So this is the ECG. What do you think is happening? What's the rate? What's the rhythm? What's the treatment? Okay, so this is sinus bradycardia. It's very simple. Slow and regular ECG, normal P waves and QRS complexes. It's just the rate is slow. Nothing else is happening. It's just a slow rate. Sinus bradycardia. Many causes. Okay, increased intracranial pressure, hypothyroid, hypothermia, hyperkalemia, hypoglycemia, drug therapy. So many things can cause sinus bradycardia. Okay, so remember, treat only symptomatic bradycardia. If the patient is not symptomatic, do not need to treat it. Red flags can be second-degree heart blocks or a third-degree blocks that you should know. So the algorithm for management of bradycardia. Again, just pause the video here. Have a good look at it and then go from there to the next. Okay, remember, transcutaneous pacing is for all symptomatic bradycardias. It doesn't always work. You basically attach pacer pads to about 80 beats per minute rate and turn up till you get the capture. Painful, many sedation. Transvenous pacing can also be done, but it's invasive, time-consuming, skilled procedure, but it's better in the long term and can have better capture. Treatment medications are vagolytics like atropine or adrenergics like epinephrine or dopamine. Okay, so the same patient had this rhythm. What's the rhythm? What's the treatment? This is a junctional escape, slow and relatively regular, no P waves, narrow QRS. It basically arises on the side near the junction of the atria and the ventricles. Okay, so it's a junctional escape. Very, very important ECG, not a common ECG that you'll see in the emergency department, but if you know about it, you'll love it. Okay, so now you have a 29-year-old asymptomatic female. You're going to know what's the rhythm, what's the management. Okay, so this is first degree AV block. Regular rate and rhythm, normal P wave with long PR, normal QRS. First degree AV block. Remember, no urgent emergency treatment is needed in this. Basically, follow bradycardia algorithm if the patient is unstable. So the first degree AV block. Okay, now you have a 58-year-old asymptomatic woman. This is the ECG. What do you think is happening? What's the rhythm? What's the management? Okay, so this is second degree AV block type 1, also called the Wenckebach's heart block. Regular rate and rhythm, normal P waves and QRS complexes, increasing PR interval until the QRS is dropped. Okay. 8-year man with syncope. What's the rhythm? What's the management? So this is a second degree AV block, Mobitz type 2. Why? Because it's a regular atrial rate with normal P wave, consistent PR interval, random QRS drop. So it's second degree AV block. So another 80-year-old man with syncope. What's the rhythm? What's the management? What's your diagnosis? Have a good look at it. This is a third degree AV block. Normal P waves, normal QRS, no relationship between P and QRS. This is basically a complete heart block. So you should know when to stop. Return of spontaneous circulation, no RSC during or after 20 minutes of resistive efforts. Possible exceptions include near drowning, hypothermia, known causes in some overdoses. If the DNR order is present, do not resuscitate order is present. Obvious signs of irreversible death. In these cases, you should stop. Okay, let's finish this. So take home points, assess and manage at every step. Rapid defibrillation is only effective treatment for VF and VT. Search for the cause, treat the patient, not the monitor. Reassess frequently, minimize interruptions to chest compressions. I hope you like this video. Do keep coming back for more. Please leave some comments below to help us improve and share.